So we're now going to move on to the UK perspective, and I'm very pleased to introduce Professor Alex Stevens from the University of Kent. I heard Alex speaking on a Radio 4 programme called Briefing Room, which was about drug deaths in Scotland just last month. I think Kirsten contributed to that too. Alex studies the overlaps between drugs, crime, and public health. He was a member of the UK Advisory Council on the Misuse of Drugs and is a former president of the International Society for the Study of Drug Policy. And now he is a member of the Scientific Committee of Drug Science and a trustee of Harm Reduction International. So please welcome Alex Stevens.
Thanks to the Scottish Drugs Forum, particularly Dave Liddell and Kirsten Horsburgh, for inviting me to come and speak in Glasgow again. As Naomi has just mentioned, I was here 5 years ago, almost the day, on International Overdose Awareness Day 2017. I was invited by the Scottish Drugs Forum to come and talk about the findings of the report that I'd written with the Advisory Council on the Misuse of Drugs on reducing opioid-related deaths in the UK. And I'm very glad to say that much has changed since 2017, especially in Scotland. Many of the recommendations that the ACMD made in 2017, which have not been picked up south of the border, are being picked up in Scotland, thanks to the work of the Scottish Drugs Forum, the Drugs Deaths Task Force, the Scottish Government, but most of all because of the people in this room, insisting that people who use drugs have human dignity, that their lives are worth saving, that we must act to prevent these preventable deaths. So thanks to you for making that progress and putting what I was able to do in paper into practice. What I'm here to do today is to talk about what's happened, something that's happened since then, partly based on work from the ACMD. Since I resigned from the ACMD in 2019 because of the Westminster government's threats to its independence. And on resignation, I was invited to join an organisation called Drug Science, which Professor David Nutt set up after he was sacked from the ACMD for pointing out some home truths to the Home Office about the relative dangers of cannabis, alcohol, and ecstasy. And Drug Science exists to act as a truly independent centre for the development and sharing of knowledge about drugs and drug policy. And I've continued to work with Drug Science on the recommendations that the ACMD put forward, especially its recommendation on making sure that people have access to life-saving services in the places they need them, and that includes overdose prevention centres, otherwise known as safer injecting facilities or drug consumption rooms. So I'm going to be talking mostly about those services today, and before I do so, I should mention the invaluable contribution made by my colleague Gillian Shorter at Queen's University Belfast, who's led on a lot of this research, but especially the work of Peter Krykant, who's here in this room, without whom we would have much less knowledge about how drug consumption rooms or overdose prevention centres work in the UK, given that he's the only person who's had the courage so far to openly set up and run an overdose prevention centre. So it's from him that we learn. The main thing I want you to take away from my relatively short talk is that there are many benefits to providing overdose prevention centres. Now, the obvious one we think of is preventing overdose deaths. So there has, as the saying goes, been no death from overdose in any of the overdose prevention centres that exist around the world. That's for a reason, because these deaths are preventable. And if they take place in the presence of somebody who is reasonably well trained and has the right equipment, including oxygen and naloxone, those lives can be saved. But that's not the only benefit that overdose prevention centres can produce. A range of benefits, as listed on these slides, for the people who use drugs and for the communities that surround them. And these are some that we've listed in the work that we've done in drug science, reviewing the sorts of reasons why people have started up and run overdose prevention centres around the world. And there are lots around the world. Thanks to the work of Naomi's colleagues at Harm Reduction International, we know that there are now probably at least 14, maybe 15 countries which have overdose prevention centres. The latest ones to have officially opened overdose prevention centres are the United States, perhaps surprising given its regressive attitudes for a long time on harm reduction, but there are now 2 overdose prevention centres operating in New York. Athens recently opened an overdose prevention centre, and Iceland also recently opened an overdose prevention centre. There's a growing evidence space from around the world, largely from the services that have been set up, the multiple services that have been set up in Canada and in Australia. And we've reviewed the many studies that are coming out of these services and have shown that those benefits that I listed in a previous slide are not just theoretical. When we do the empirical research, we find out that these benefits come true in practice. And the benefits are there not just for people who have problems with drug use, but for the communities that surround them. So we know that these services reduce deaths. We know that they're effective at engaging. Well, we've used hard to reach here. It's not a term I particularly like to do because it's not that hard to reach people on the street who are using drugs, is it? We know where they are. They are more that we are hard at. We find it difficult to provide the services they need rather than finding it hard to reach them. They facilitate access to other forms of healthcare. And that might include drug treatment, but all the other forms of healthcare that people need, dentistry being a prime example. So there are benefits there, proven benefits for the people who use drugs, but also proven benefits for those people who are living in the communities around them, who are often, perhaps understandably, given the hysteria and stigma that surrounds this issue, worried about what's going to happen if somebody sets up an overdose prevention centre in the neighbourhood. But what we find actually happens is that crime, rather than going up, actually reduces. There's an unsanctioned overdose prevention centre somewhere in the States, that for a secret location, so secret, apparently I'm told, there are some people who inject drugs in that city who don't know where it is. They've had to keep it secret, otherwise it would have been closed down in that particular state. But they've done a study of the crime rates in that city, actually went down after the introduction of an overdose prevention centre. And that's a common experience, because people are no longer using drugs on the street. They're no longer congregating in those car parks, alleyways, disused spaces. They've got a place where they can use drugs safely. They're not dropping that litter on the street. We've been doing the Drug Science Enhanced Harm Reduction Working Group has been done quite a lot of work with Cranston and Sandwell, and Matt Southwell created a group called SCORE, Sandwell Community Outreach Engagement, a group of active injecting drug users who showed us the places where people are injecting drugs. One of them was a disused church with a floor that was dangerously, the building had been condemned. There shouldn't be anyone inside it, let alone injecting drugs very regularly and leaving very large amounts of drug-related litter. That group set out to engage people who are in that area about finding out what they wanted from an overdose prevention centre, and also doing that by going and clearing up these spaces because they wanted to give something back to their community. And those people in that community told us that they are tired of seeing people injecting in stairwells in their housing estates. They're tired of seeing them inject in the car park outside the supermarket, and they understand the reasons why. It would be better to have somewhere where people can use without being stigmatised and shamed for using in public. Both the public and the people using drugs, who are the same people, want spaces which are safe, clean, and out of public sight to be able to use these substances. So Peter recognised this need and recognised nobody was actually doing anything about it. People like me had been pontificating about it for years. Wasn't actually happening. So Peter took the courageous decision, at great risk to his own health and liberty, to actually open an overdose prevention centre. That was formally announced on Overdose Awareness Day in 2020. It was opened to its first injecting a few days later in a converted vehicle. That vehicle broke down. It was replaced with a converted ambulance, which provided a greater capacity and a better service to the people who are using it. But it was fairly low-key advertising, just a flyer in local streets saying this service is going to be open. And as that service developed over those months from September 2020 to May 2021, he saw an increasing number of people using that service as they came to trust it. Now, we worked with Peter to try and document some of this work, But understandably, we didn't document all of it because Peter and his volunteers were too busy sometimes providing these services to write down on the forms that we provided. But we did, or he did, document 849 injections by people who had a mean age of 34 and a range of between 20 and 65 years old. The majority of them male, perhaps unsurprisingly. At that time, many of them were living in hotel accommodation that had been provided during the pandemic. And the headline is, nobody died. Indeed, overdoses were reversed. 9 overdoses were recorded as being reversed during the operation of that unsanctioned overdose prevention centre, 2 from cocaine users and 7 involving opiates. That covered 8 individuals, one person overdosed twice. All of them survived. There were 2 ambulance call-outs, one of which was reversed. And here is another interesting fact about overdose prevention centres, which is that one of the ways they reduce costs in the health service is by reducing the call on our colleagues in the ambulance service. And one of these is particularly interesting in that there was a reversal of a call, presumably a 999 call to the ambulance. The person, having been given naloxone and oxygen, became so well that they didn't need an ambulance anymore, leaving the ambulance free to go to one of the many other calls I'm sure they have on their time. So this is not, again, not just benefiting the people using drugs who have their life saved, but the community who also needs their life saved in other calls that the ambulance might have had. Let's dig a little deeper into the data that we collected. You'll see that there was, initially people didn't know about it. It was only operating for a few hours a week in quite a small vehicle. There was not huge uptake. But when the service was put into a bigger vehicle and people started to get to know what was happening, there were a larger number of people coming for a larger number of injections. And you'll see also that there was quite a lot of repeat business, if you see what I mean. People who got to know the service, got to trust the service, realised it was a place that was safe for them to inject. And I think that helped that the police weren't interfering. So contrary to the UK government saying these things are illegal and we're going to shut them down, this was not shut down. The police knew about it, obviously observed it happening. There was an interaction between Peter and the police, but Peter was never charged and certainly never prosecuted for any criminal offence in relation to the operation of this service, and nor were any of the volunteers or any of the users of this service. It is possible, Peter showed, and we have documented, to run one of these services without being shut down for legal reasons. And once they know that it exists, people will come back. One of the things we know about overdose prevention centres is that they'll need to be different for each location they're put in, which each country, each community might need a different form of an overdose prevention service, depending, for example, on what people are using. And one of the surprising things to me, more used to English patterns of substance use, was that the majority of people who were injecting at Peter's Overdose Prevention Centre were injecting powder cocaine. I mean, that's an interesting finding in itself, given that that has not been widely documented in the academic literature, even though many of you will know that's the situation. There was also an interesting difference in gender patterns here. So women were more likely to be injecting heroin than men, suggesting, as Naomi says, this intersection we need to be paying attention to and the specific needs that different genders may have. And the location of injecting is also interesting because people were injecting in perhaps some of the most concerning places. So these are people who are engaging in practices that are highly risky to themselves. And another thing that injecting an overdose prevention centre can provide is safe places to do this under observation, but also advice on how to do it. So my colleague Magdalena Harris at the London School of Hygiene and Tropical Medicine makes a lot of noise about how people can be helped to use in a way that is less dangerous to themselves, even if they continue to inject. And so, for example, we can reduce abscesses and drug-related infections through not only providing clean equipment, but also helping people with their injection technique, so they're not doing so much damage to themselves when they're injecting. It was interesting to find that the majority of the people who came to use the service were in some form of opioid agonist therapy, a methadone or buprenorphine. But there's also an interesting group here. So that shows that that treatment they're getting isn't meeting the whole range of needs that they have. And it also shows that there's still a substantial group that are injecting heroin or cocaine in public places that aren't yet in treatment. And that is the group to whom overdose prevention centres offer a beacon to show them not only can they improve their lives by using these services, but there are people in the community who care whether they live or die. And that is the practical aspects of compassion and this communication out to people that there is love and care for them still, that an overdose prevention centre can provide, as well as the clinical, practical, technical services that they provide. We also did a lot of documenting of what people told us, and told Peter, told the volunteers about these services. And it's not just about technical opiate or cocaine-related harm reduction. It's about all the other things that people have going on in their lives. So there might be things like DVTs or blood clots or abscesses that are related to their injection. But there's also things about whether they've got any access to other forms of medical care, whether they've got mobility issues, whether they've been victims of violence. I did research years ago showing that people who are injecting drugs have huge rates of violent victimization, and that's very often under-addressed. And we need to reach out, we need services that can reach out to people in the community who are being victimized as well as being marginalized and offer them protection. So it's not just about injecting, it's not just about the drugs, it's about a whole range of social issues that people have. And as Peter and his volunteers got to know more about what they needed, well, they needed food. This is winter a lot of the time. They needed warm clothing, warm, new clothing, not just second-hand cast-offs, but new clothing that reinforces that message to people that we care about them, that society values them, and we don't just give them hand-me-downs. In one rather extreme case, there was a gentleman using the service who'd been, for at least several weeks, due to his mobility issues, in a wheelchair, and his wheelchair was missing a wheel. This sort of humiliation of having to push yourself around the city or be pushed around the city on a faulty wheelchair, and nobody has provided what that person needed. And an OPC is a way of making that connection, providing that service. Now, the UK government, if not the Scottish government, is making the case that we can't do this because it's illegal. Now, that's not true. There is no part of the Misuse of Drugs Act 1971 that makes it illegal to provide a space where people inject opioids. Weirdly, it is illegal to run a space where people smoke cannabis or smoke opium, but it's not illegal to run a space where people inject opiates. There are obviously criminal offences that would occur in an overdose prevention centre, possession of controlled drugs being an obvious one. And so we suggest, and have suggested in drug science and with our colleagues, that a simple way of clarifying this legal grey area would be not to go through the whole rigmarole of changing the Misuse of Drugs Act, which requires primary legislation and debates in Parliament, but to change the Misuse of Drugs regulations, which can be changed effectively at a stroke of the Home Secretary's pen. And the Misuse of Drugs regulations already exempt various activities from prosecution under the Misuse of Drugs Act. For example, nurses providing drugs on prescription are exempted from being prosecuted for possession because they're obviously in the process of providing drugs for medical use. Now, we could change the Misuse of Drugs regulations to exempt the people who are running and using drug overdose prevention centres from prosecution. That would be a lot simpler than doing it through the Misuse of Drugs Act. So, as my last slide, I would appeal to you, if you have not already done so, please could you join us at Drug Science and the Faculty of Public Health in adding your names to this call that the Westminster government, the UK government, make changes to the Misuse of Drugs regulations in order to make it easier to run pilots and services for overdose prevention. Now, and I'm deliberately saying making it easier, it is not impossible to do this under the current legal framework, and Sackett, I assume, will be telling us about what the Scottish plan is to try and do that. But it would be a lot easier to do it, and people who are running a service would be a lot more assured that they won't face prosecution if the misuse of drugs regulations are amended. So that's my final plea to you. Thanks very much for listening. Good luck.